to one of your meetings and did a little spiel. It's been a while. I'm hoping going forward to be more prevalence in your area. We'd like to start collaboration between the documentation and what we're filling out of the system to make sure that we all match. And of course, you're getting what services you provide, you're getting credit for it. So for today, we wanted to really quickly just go through what's an E&M. I know you've been doing some work with Betsy on the front end. I'm just going to talk about what we're seeing on the back end because it's our coders that are combing through these records and that documentation and ultimately assigning a CPT code for the services you provided. And then I'm going to really quickly review the documentation requirements when working with a mid-level versus working with a resident, and then talk about some next steps. So a high-level view of what really happens when the patient's registered, the services provided, the services documented, we get the record in HIM, now it's electronic. If the record's complete, we're able to code it, charge it, bill it, and hopefully get paid for the services that were provided. If it's incomplete or anything's missing, those are the queries that the coders are sending back to you, asking for some further documentation and or clarification. Then it starts that whole process over again until we get it complete and we're able to bill for the services that were done. So what's an E&M? It's an evaluation and management service that you provide. It communicates to our third-party payers for reimbursement and is directly related to the E&M codes that we submit. It also creates a billing pattern profile for each of you within the facility. We're able to compare that pattern to your peers. We can probably compare it to what's going on in the community. And nationally, we used to have the national data, it got a little old, we need to acquire some new data. And then again, it's used for statistics and health information management and care, because ultimately all that stuff doesn't get reported to the state. No code, no dough. The complexity of the patient's condition as documented in the note is what drives our level of care. And it's directly related to the services you provide and what's documented in the chart. If it wasn't documented in our world, it wasn't done. So if it's not documented, we can't code for it. In the emergency center, we have 5 levels of E&M, level 1 through level 5. My level 1 is opposite of your level 5. Our scales are reversed. So you see a patient that you call level 5, I'm calling that a level 1. So I don't want to get that confused with you. And then of course, critical care, 99291 for the first 30 to 74 minutes, and 99292 for each additional 30 minutes. And it's a whole topic in itself that I'm not going to really touch on today. We'll save that for another day. So medical necessity, we only can bill for the services that were medically necessary, and that's established through your note. That's going to communicate to us why the patient was here. So in determining the level of service, it's based upon how sick the patient is and what the documentation requirements are. So of course, if the patient's feeling really well, it's probably a preventative service. Those are the ones we hope we don't see in the ED. Versus a level 1, I'm not feeling too well, and a level 5 is you're really sick. Level 1 to 2 is minor to low moderate severity, and levels 3 through 5 are reserved for moderate to high severity. So what's an E&M? It's based on 3 components, your history exam and your medical decision making. In the ED, you have to have all 3. If you skip one of those, we can't bill for anything related to an evaluation and management service. That's why we're always sending queries back for more information, because if it's not there, we can't bill it. So your chief complaint is just a quick summary of in the patient's own words, why are you here? It's required for each note, and it's going to help us establish the medical necessity for that encounter. I want to talk about just the history for a minute, which is the blue bubble, if you will. Within that history component, there's 3 components. There's a history of present illness, review of systems, and a past family social history. You have to have all 3 components within that one component. The review of systems and the past family social history can be recorded by your ancillary staff. In the paper world, it used to be the patient. If you had them fill out a piece of paper and they check off all these review of systems, we could count that. In the electronic world, it's a little bit more difficult, but you can also count from your resident and or student. But there has to be a notation that you as the provider reviewed it. We cannot assume that you reviewed it. So your history of present illness encompasses 8 elements: the location, quality, severity, duration, timing, context, modifying factors, and associated signs and symptoms. We stop counting at 4. You max out at 4, but please document what you need to clearly document what's going on with that patient's condition. And it's not 4 per complaint, it's just 4 overall. Your review of systems, there's 14 of them. 10 is a complete review of systems. We count only pertinent positive and or pertinent negative review of systems. There is a caveat for you. If you document at least 2 pertinent positive and or pertinent negative review of systems and make a statement that says all their systems reviewed and were negative, you get credit for 10. That statement should never be used by itself. There has to be some documentation of a review of system.
When you do the review of systems, like if you do cardiovascular, can you just do like on our, what we have on our template, can you just do one of those things?
I'm going to count that as one system. It doesn't. I don't count the elements within the system. I count that as one system.
Right, so whether you put 3 things checked off there or one thing, you still are getting credit for that one system.
Correct.
Karen, can you just say that again? So you can put 2 things on there and then all other review systems.
As long as you have at least 2 pertinent positive and or pertinent negative in that statement, you get credit for 10.
But with that statement alone, there is no credit for anything, correct?
I would never use that statement by itself.
Perfect.
But also keep in mind, if you free text in your HPI, I can pull review of systems from there and count that also all their systems reviewed as per HPI. But if it's not in the HPI, it's not there. So if you keep that in mind too. I also cannot double dip. If I count it for a part of my HPI, I cannot count it again for review of systems. You get 1 credit if it's in the HPI.
Karen, I just point out here that when someone makes the statement, all other systems are negative, there's actually something to back that up. That you don't just check that off. You really should be careful in how you use that.
That's exactly why I want to clarify.
Because they have as easily an electronic record. You can click a box, everything's negative, and quite frankly, unless you actually ask the patient about that, you really are
Yes, correct.
being fraudulent. So you have to be really careful how you use that particular phrase.
I would say for the most part, since you've gone to Cerner and the electronic record, most of the physicians are pretty good about documenting a pretty meaty review of systems, if you will,
Right.
that all that is in there.
Yeah.
We haven't had issues with that one.
And if you can't ask for review systems for a intubated patient, or you
Yep.
can talk about it, right?
Yep.
Yeah, that's-
Your past family social history is credit for each one, and again, it doesn't count the number of components within the past history or the family history. If you talk about smoking, you're going to get credit for a social history. Does that make sense? Medications, you get credit for past history. For a level 4 and a level 5, you have to have at least 2. And I think for the most part in the electronic record, we found we're not short on family history, past history, or social history, because you always ask about smoking, and you always review the patient's medications and or surgical history, so you have credit for 2.
What about on our Cerner, on our template, or for example, for family history, we have a choice of not significant. If we click that, is that counted as for its family history?
You're going to get credit. I realize for your 80-year-old patient or 95-year-old patient, the family history at this point really isn't relevant. I look for more like family history not relevant to presenting complaint, but if that's the choice in Cerner, I don't know that we're able to alter it, you're going to get credit for the family history. But I would hope that if something is significant, that it is written out in there for your younger patients, family history, cardiovascular disease, that is written in the chart. When the credit is unobtainable, your patient's trachs, not conscious, you have to tell me why you can't get it. You just can't say history unattainable. Patient not conscious, patient has a trach tube in, something to tell me why. Otherwise, we have to count the components. If it's not obtainable because they are unconscious, you're going to get a full credit for a history component based on just this documentation of why you can't obtain the history. patient that came in with chest pain from a chart, and I kind of circled out where it fits into the history component. So I took a quality, a location, associated signs and symptoms, and a duration and a timing. When does it happen? For just this history component on this patient's chest pain chart, and I gave credit for 4 or more in that HPI component. From the review of systems of this patient's chart, I pulled out some from the review of systems that was spelled out in the chart itself, but then I also pulled some out from the HPI, again, not double dipping. So from this chart, I was able to get a complete review of systems with this little caveat note in the chart, and a combination of the two. Also within that, this patient's chart, there was no past history, social history, or family history documented, so that got a score of 0. So overall for this patient's chart, without the past family social history, dropped the HPI component down to expanded problem focused. And when we go through this code, you'll see how it changes the code at the end of the presentation. For your exam, we follow 1995 guidelines and count body systems. If you document 8 systems, regardless of the meat that's within that documentation, you're going to get credit for a comprehensive exam, versus if you document a problem-focused visit, and there's just a little bit in there on that one system, you're going to get a problem-focused exam. If you do 2 or more systems with a little bit in each one, expanded problem-focused. If you do 2 or more systems with a lot expanded in the system to the presenting complaint, you're going to get a detailed exam. So for that same patient's chart, I was able to get 8 or more systems for this patient, so this came out to a comprehensive review of systems. Excuse me, comprehensive exam overall. The last piece, the yellow bubble, if you will, is the medical decision making, and like your HPI, it has 3 components. But unlike your HPI, we only have to have 2 out of 3. So you get points for the number of diagnosis and or management options to be considered. And for you guys, most times, each time the patient comes in, unless they're a frequent flyer, it's going to be a new problem. Patients coming in because they have a new problem. And it's going to be new problem, no additional workup plan, you're treating it and sending them home, or it's a new problem and you're going to do further workup, you're admitting them or sending them to a specialty provider to take care of the presenting complaint. Also along with that, if you're managing the patient's hypertension, if it's a significant medical issue that is chronic, that's going to affect what you're doing for that treatment now, you're going to get additional points for that as well. That's in the top 2 categories.
So Kara, this is in your paragraph at the end, or in your differential diagnosis and
I'm going to pull it from your assessment and plan.
assessment plan?
You also get points for data reviewed or data to be reviewed. You get a point for labs, and it's not a point each, it's just a point overall if you're ordering some labs. You get a point for nuke med, all imaging, except echo and heart cath. You get a point if you're ordering a chest x-ray, distal radius, fracture x-ray, you get points for all those. Same with your EKG, EEGs. If you interpret the tracing and document the interpretation in your note, you get 2 points. If you talk to the physician who performs that test, and it's documented in your note, you get a point. If you have to obtain old records or history from some other source because the patient's not conscious, and you summarize that in your note, you're going to get a point or 2 points based on just that documentation as well.
So if you just pull in your labs into your note, did that count as one?
I am not, because to me, I would look for a documented interpretation of that lab if you just did a quick summary on the bottom, like the patient's troponin was elevated.
There is something actually at the bottom, you can say like consistent with prior or normal.
No, but I'm not talking about that. I'm just talking about
Pulling the
just
labs.
drawing it in, okay, and including it in your note which you're signing. Therefore, in essence, if you're signing that note and it's in your notes, you've looked at that.
I'm still going to put it in with the points overall for the lab order itself as 1 point.
Right, that's what I'm.
Yes.
Okay.
Yeah, but if you pull labs in from Rio or UNet,
To me, that's decision to obtain from other, the Rio would be taken, if you had to break the glass to find something and you pulled that into your note,
yeah,
I would take that as obtaining old records from another source as a point.
okay.
And I know with the electronic record, when you're pulling in all these notes into your note and pasting in like a chest x-ray, it makes for a pretty long note. And to me, it's almost like note float. You're just reiterating what we have stored in another area in your note as well.
So you just need to summarize it, not actually read it.
And another question, since a lot of this information, a lot of us do not put under decision making, however, this information is present in the note itself, like EKG, by X-ray, so you guys are looking at those things.
We're looking at, yes, we're looking at the whole note in its entirety and pulling each one of these out as we go along. The medical decision-making piece is your risk based on the presenting problem, a diagnostic procedure, or management options you're selecting. And it's based on these 12 boxes. There's minimal, low, moderate, and high. Any place within these 12 boxes where you can pick what you're doing or ultimately how you're going to treat the patient, I would take the higher over the lower. And we just like to point out quickly, prescription drug management, any kind of prescription drugs, you're already at a moderate risk. Undiagnosed new problem with uncertain prognosis, moderate risk. Acute MI is down here, also a TIA, seizure weakness, those are all high. But also pointing out that one or more chronic illnesses with severe exacerbation versus mild. We would look to your descriptors in your note to decide which, is it moderate or is it high? Where are we plugging it into to show what's going on with that patient? So from that same patient's chest pain, from the medical decision making, I pulled out a new problem, no additional workup plan. The patient's going home. They had some lab tests, a radiology test, an EKG, an interpretation of that EKG, and I pulled out moderate medical decision making. So when you piece all that together, I only have to have 2 out of 3 for my medical decision making, unlike my HPI. That brings us down to a moderate overall medical decision-making risk. And when you piece that all together with the previous documentation of that same note, that lack of past family social history is what brought this whole code level down from what could have been a 4 to a 2. So if anything is missing, HPI, review of systems, we do send queries. We're trying to capture that information. Or if an exam is left out in its entirety, this is why we're sending it back to get some additional data, because it's very important at which level we select based on the documentation that's in the chart. Does that make sense? Anybody have any, does that make sense?
Just as quickly, for like past history, we have options to just click like reviewed as per documented in the chart. Are we getting credit for that, or not specifically itemizing their past medical history and past?
As long as it's documented in the chart somewhere. I know there's an issue with the problem list not being updated. I don't know if you guys refer to the problem list that's in the chart. If it's reviewed within the chart and I pull off that ED note by itself and I don't have any past family social history in there,
Just aren't.
It's gotta be
if you-
that note, not the patient's overall chart.
correct. Because that note, if it ever got audited by the OIG or Medicare, they're looking at just that note by itself. They don't have the whole medical record in its entirety. That note has to stand by itself.
So if we don't specifically put it in our note, even if it's documented in the nursing note from that visit, or
If you
what have
see, please see nurse's note and it's there as a coder, I'm gonna go to the nurse's note and look for it. Because you're telling me where you got it from and where to go get it, that's where I will go get it. But if it's not in her note or his note, it's not in the nurse's note.
It's usually from prior visits or past visits.
But also the tradition to the nursing history.
But I see notes, they have 27 diagnoses on them, where some people have just pulled in problem lists from everywhere. And obviously, it's not a very good idea in and of itself, because some of them resolve problems, there's all kinds of things there. But again, similar to Dr. Wool's comments, if those are included in the note, in and of themselves, do they suggest that there's been a review that
you're telling me as per note, I would assume, and you're signing off on it, that you looked at that, and if it is resolved, it's documented, versus just pulling it in and pasting it and not saying anything about it. I would look to see that you reviewed it as per note. To me, you're signing off on it, that is the history component.
And then for the medical decision-making, we have the option just to click like review prior ED visits. But if we don't specifically include something about that, if we just click that we reviewed it, are we getting credit for that? Or we have to specifically pull in something?
If it's something that's relevant, I would give you credit for probably reviewing the points for the decision to obtain old records, looking at old records, but I wouldn't know specifically what you were looking at unless we went and pulled those out. So I don't know if that's something you should include in your differential diagnosis. When you do differential diagnosis and you're doing signs and or symptoms, we can pull from that information as well, versus just review the records. I guess I would look specifically what were you looking at.
I guess that's my question. Do we have to say, put in an additional line in there saying that what we looked at, or?
I know in the paper world, which I would probably carry forward to the medical record world, if in a chart you told me reviewed previous records, I would look for at least a date of service. What date of records? Because if it's a frequent flyer and they're here, I wouldn't know specifically what you were looking at.
I usually free text that I obtain information with the video.
And I would give you a point, I would give you credit for that. I love free
In that
text.
other box where it says obtained documentation or reviewed prior conceived visits or prior admissions, and then there's a other, that's where I bring the re-up information.
You're going to get credit for obtaining old records from another source with that. From the RIO and what you're pulling in, I would give you credit for that.
But back to Marissa's too, this is kind of a big point. So if we're not putting anything in there, we're not getting any credit for it.
I would not give you credit. In
It's
some,
a reference, something.
Yes.
It's reference.
if you reference what you were looking, if it's a date of service, I would know to go look at that.
Yeah, I don't think anybody does that.
Karen, one of the issues is that you can make a level 5 out of anything.
Correct.
Right? When you're not there. Are there some general comments that you have for the ED physician? If somebody comes in with a cut finger that requires a Band-Aid, to document something like that and not spend time, would you have any words of wisdom here? Because part of the issue is that the ED, I assume, is in aggregate is profiled compared to whatever the feds or other insurers would be looking at as profiling. And are individual EC physicians profiled as well in some type of national report that you receive or from? So two things. Document the appropriateness. If somebody comes in with a sore throat and there's nothing else going on, they shouldn't code out to a level 5. And what about our profiling as an ED and individual EC physician profiling?
For the medical necessity review, you can document everything comprehensively and think you're going to get a 5. We always state that the medical decision-making should drive the code. So if a patient comes in with otitis media, on paper it's probably a 4. There's level 3 and level 4 both moderate, but it's high moderate versus low moderate. So if a patient's coming in with otitis media, I would not expect a comprehensive history, a comprehensive exam for that otitis media. You only need to document expanded problem focused and expanded problem focused. So just because everything's documented to the hill and it supports a 5, it's not necessarily a 5. And that's why the coders go through and actually weigh out the points in the systems for the medical decision making. All these levels go to Sparks, which goes out to the state. They can easily pull for data review to look at the levels that ED physicians are providing. Their names are attached to it. I would assume they would be able to pull that information right out. It is recorded, it's not.
I know that the reason I bring it up is I know the practices are, I believe it's still something that occurs in the practices. I used to receive my report of office coding and compared to national reports. I
Yes,
believe.
that's the one where the data was bold, where we were shifting, we were trying to shift our bell curve. So we stopped producing those reports because the data we were comparing ourselves to was bold. We're working on getting that reestablished so we can see each individual provider and then compare to their peers where they stand. So we can monitor.
I think the important point that Dr. Salvani is that we code to the best of our ability
just want
We
you,
can do everything, yeah,
yeah,
that's exactly.
for you guys too, because I'm documenting all this stuff, it should be a 5. We're actually going through and basing it on medical decision-making, and then backfilling it with enough information to support that level of service.
And the idea here is, again, not to make the providers coders by any means. The idea here is to get us up to a level where
Right,
these guys are having a better
yeah,
time of documenting at the highest level we can, or is appropriate.
right.
Just a real fast question, as far as decision making, so if I read an EKG and I also say no difference from the EKG on 12/25/2012, do I get 2 points because I'm reading the EKG and I'm comparing it?
You're gonna get 2 points for interpreting that EKG regardless.
Yeah.
So if
and
you do your interpretation of the EKG and you ordered it, there's 3 points.
And then what about that I'm saying that I compared it to a previous EKG? Do I get another point for that?
2 points in it.
You max out at 4 points, I should say that too.
Right, no, what I'm just saying is that there may be a
Decision
possibility where you can max off in your decision making for 4 points just by doing the EKG and comparing it to the last one. Is that true?
You could, yes, because you're gonna get obtain old records,
Suspend, you can take a
interpretation.
shortcut.
Right.
Straight to the EKG and document one thing really well.
Nice point. When working with mid-levels versus when working with a resident, when you're working with the mid-levels and you do a split shared visit, we would like to see, I just don't want to see seen and agreed. For that, you're not going to get any credit. We're going to bill it out under the mid-level service. There has to be some documentation to support your participation in that patient's care and that you saw the patient's, the white of the patient's eyes. You were in the room, you saw the patient. We have adopted here at Unity documenting 2 out of the 3 key components. So I've seen you guys do it in your note on the bottom to say your own little exam, your medical decision making, whether you agree with the mid-level or you don't, and here's why, or how it's going to change. We do not want to see agree with above, seen and agree, patient seen and evaluated. Those kinds of documentations, yes, you're signing off on it with a co-signature, but the billing service is going to go to the mid-level, not the MD, based on these co-signatures. There has to be evidence of participation in that patient's care. When you're working with a resident, you actually can bill for that resident's service and/or procedure they perform under your name. You do not have to redocument all those history of present illness, the exam, and the medical decision-making that the resident already did. But again, you have to show that you saw the patient's eyes face-to-face, I participated in the care, and that you agree or disagree, and here's why, but not have to do the 2 out of the 3 components. But for me, it would show that you did participate in that patient's care. Again, we don't want to see agree with above, seen and agree. You have to show presence of participation. What we're hoping to do next quarter, starting next quarter, is to rotate, I'm going to rotate through each provider with audits, like 10 charts, not really an audit, just a review to show you that, hey, if you did this, we could have billed this, just to give you guys some feedback to see how it's working, and hopefully be a standing item on your agenda each month to go through some of these segmented questions and just break out education based on what we're seeing.
So, yeah, that's exactly the idea, guys, is that, and that's why we have it taped too, because I think everything that, Karen actually came to me early last week with like a packet, I don't know, it was like 40 slides or something, but it was probably everything that we have wondered about, and like there's all these rumors in the department about like the mid-levels documentation, the resident documentation, and you know, even just the E&M stuff like Wolf is, you guys have been asking about today. So the idea here is to kind of put this thing to bed and to have documentation of Karen actually speaking to come back and say, you know what, I'm going to review that section from last month's provider meeting to say, what do I do for a physician or a mid-levels chart or a residence chart or something like that. So she's going to come back probably the next few. And funny part is, you said audit, but I know the idea here is not punitive. So we're going to get away from the idea of an audit, and it's simply a review, okay? And Jamie's going to be working with everybody probably 15 to 20 minutes before a shift over the next quarter to come in and go through those 10 charts, and Karen is going to look through all of them and give you constructive feedback as to how to improve it. And the our level is, our appropriate level is, based on our documentation. It's twofold. It's institutional-wide, first and foremost, and secondly, that we're also moving towards the RVU system as we come to the first quarter next year as well. So,
Yeah, Karen, first of all, great job. I thought this was
Thank you.
exceptional, okay, as far as the information that you gave us. And second of all, just, I think for all of us guys working and girls working downstairs, can you just give us kind of like some real world numbers as far as revenue, the difference between a level 3, 4, and 5?
Yes.
From the insurers, just so that we can get a feel of what's the difference between a level 3 and say level 4 and 5?
It's going to be different by payer, but we can get that information for you. And also keep in mind, there's a pro fee for what you guys are billing for your service, but we also do bill out a facility E&M level as well, which I won't throw that in front of you. But there will be sometimes a difference, or maybe more work on the facility side than the physician, or vice versa. So that information is in there. But we are working to get that data in your levels in front of us, so we can see, hopefully, that we are making a difference going forward. So hopefully we'll see all that.
Do you just have ballpark numbers?
I don't off the top of my head, but I can get that for you. We'll get it based on payer too, so it'll be different.
you guys have any more questions for Karen or Betsy? Alicia does.
Moving forward, for any who might come on in the future, I would assume that perhaps this would be something that can be required to orientation, because when I first started here, I actually hired a working AED who we were required to sit with someone and to go over the T system and appropriately learn how to do review of systems and coding. I thought it was really helpful.
I would like to make this a working relationship going forward, because we are quoting your charts, we're looking at them every day. To be a face that you know, and if we have issues, we can come down and talk to you sooner rather than later. Because you guys see so many patients, to be able to recall that information 10 days later is probably not a good idea. And I don't want to fabricate something that's not there.
This is helpful